have not much time, I think. We can come to the Roger Hartl session, and I want to invite Dr. Roger Hartl and Giovanni Grasso will be the interviewer. Is he with us?
Hello, everybody.
Can you? Yeah, Giovanni is there. Right.
Roger, welcome.
Hello. Oh, thank you so much for having me. I've been listening to this, and it's been a fascinating discussion so far. Thank you so much for having me.
Okay, it's
Can you hear me?
Yeah, it's a great pleasure to perform this interview today. Dr. Hartl doesn't need a great introduction. He's a well-known figure in the world of neurosurgery. He's a world-renowned pioneer and leader in minimally invasive spinal surgery, computer-assisted spinal navigation surgery. He also the founder and director of the Spine at the New York Presbyterian at the Weill Cornell Medicine Center for comprehensive spine care, as well as Weill Cornell Medicine Global Neurosurgery Initiative in Tanzania. And Dulcis in Fundo is also services of the official neurosurgeon for the New York Giants football team. Is that correct?
Yes, yeah.
Okay, it's just a summary. Okay, so I shoot with the first question. So we have been at the forefront of integrating advanced technologies like navigation and augmented reality into spine surgery. Can you share with us how these innovations have transformed the surgical procedures and, above all, patients' outcomes?
Sure. No, thank you. Thanks again for having me. And that was a very kind introduction. As you know, we're all on the shoulders of giants, right? We only get to where we are by listening, going to the meetings, learning, and honoring the people who are our mentors. So I want to point that out. Without those, we wouldn't be anywhere. But in terms of new technology, and we heard about augmented reality, and we talked a little bit about navigation earlier. We saw that video from our colleague in Germany. You know, I've always been fascinated by it, and I think especially with augmented reality, some of you were a little bit hesitant to really acknowledge the potential value. But I think that as we kind of mature as surgeons and as our infrastructure in the hospital improves, I think navigation and augmented reality increasingly are going to become very, very important. We have already, in terms of patient data, we have a lot of data showing that the correct use of 3D navigation, freehand or robotic navigation, increases accuracy of implants. And that's kind of, in my opinion, that's the low-hanging fruit, you know, because it's relatively easy to measure, and it's something that intuitively makes a lot of sense for surgeons to use navigation, especially in percutaneous cases, for orientation and to improve the accuracy of screw placement. Now, when it comes to augmented reality, though, I think that's really the next step up. And augmented reality, at least in North America, is being used with those goggles rather frequently now for the same purpose, to put in screws, and it seems to work very well. But what I'm really excited about is the use of augmented reality, not only to put in screws, but also to facilitate the workflow. And Ahmed, the colleague earlier, showed a slide that we put together where we use augmented reality with the operating microscope to guide surgeons through a complex spinal operation. So not only to put in the screws, but really to show them surgical landmarks. You know, this is where you make the incision, this is where the facet is, that's where the lamina is, and then that's where the pedicle is, that's where the disc space is, that's the orientation of the disc space. So rather than, especially in minimally invasive surgery, rather than guessing and getting tons of x-rays, you use your exoscope, your microscope, and you dial in those landmarks that you need to perform the operation step by step. And then we're getting to augmented reality as an orientation tool to facilitate the workflow. And that's great for teaching and training, but also for advanced surgeons, it's great because it just helps you orient yourself while you're doing a complicated procedure. So that's kind of but we don't have data on that yet, other than from the lab where you can show that using augmented reality facilitates the workflow. But I think we'll get there. And I think as we all become more confident with goggles and using augmented reality through a microscope, we'll get more experience, and we'll really integrate this into the surgical workflow. I hope that makes sense. That's kind of my view.
Yeah, thanks. The second question is how, in your opinion, the minimally invasive approach changes over time?
Yeah, so I've always been interested in less invasive and minimally invasive surgery, of course. When I decided to become a spine surgeon 25 years ago, I was very depressed, okay? Because I thought I'm never going to use the microscope again as a spine surgeon. And I really enjoyed navigation. I trained in brain surgery using a lot of navigation in the late 90s, early 2000s. So I really understood the value of navigation. And I thought, I'm never going to use navigation as a spine surgeon. I'm never going to use a microscope. And now see what happens. Over 20 years later, as spine surgeons, we use the microscope more than a lot of our cranial colleagues. We've gone from endoscopic procedures, tubular procedures, percutaneous screw placement. Look at all the evolution and how exciting and how really, amazing it has been. Now, then the integration of augmented reality, as we just talked about, and not only for screw placement, but really to facilitate the workflow of any spine operation, maybe also in injections like pain procedures at some point. Why not use augmented reality for that? The next step is biologics, for disc regeneration, disc repair, not only for fusion, but disc regeneration, disc repair and replacement of discs at some point. And we're just at the beginning of this. And then finally, I think what makes you really a successful minimally invasive spine surgeon is if you make the right decision. And that goes beyond surgical techniques. So you got to examine a patient. You got to figure out exactly why is this patient here? What's the pain generator? And that's where the multidisciplinary aspect comes in that you mentioned initially. I think to be a good spine surgeon, we have to work with our non-operative partners because it makes us better surgeons because we make better decisions. If you only know how to operate and you try to find an operative solution for every problem, you're going to make a lot of mistakes. But you got to surround yourself with a multidisciplinary team that helps you make these decisions. I love that.
Perfect. So I had also another question, and is about your experience in Tanzania. Can you share with us your experience, your thought about this action?
Yeah, thank you, Dr. Grasso. So Tanzania, we've had a project there for the last 15 years, and Dr. Shabani, I think, is on this call, and I think he gave a presentation earlier. Hamisi Shabani is really my partner in Tanzania, together with many others. And it's been very, very worthwhile because we started out a collaboration. It was just about teaching and training fellows and nurses, anesthesia, ICU people who would go back and forth between New York and Tanzania. Then it was about research activities. We wrote more than almost 40 papers. We published almost 40 papers over the last 10, 15 years together, all related to head trauma, spinal trauma, hydrocephalus. And then more recently, we've been trying to do leapfrogging, bringing technology over there. So we've been bringing a navigation system. BrainLab was generous to donate a navigation system that's being used now on a daily basis in Tanzania at the Muhimbili Orthopedic and Neurosurgical Institute. We have an endoscopy tower donated by Joymax, which is being implemented now. I was very hesitant to bring technology there, but now with the collaboration and the interest, we see that even bringing technology there can work very, very effectively as long as you have a service contract in place, you have a service contract with a company, and you have the right champion surgeons locally, such as Dr. Shabani, Dr. Ruta, some of the other surgeons there who really are interested in integrating that technology into their practice. And now, as the next step, we're trying to work on a center of excellence in Tanzania not only to prevent surgeons from leaving Tanzania, but also to prevent patients from going elsewhere, because you need to support these institutions locally, not only to prevent a brain drain, surgeons going abroad, but also keep the patients there. If you can keep patients there and treat them locally, I think that's going to be a huge plus for the institution and for the whole program. So that's kind of my take on Tanzania. So we started little, and now we're kind of getting to really supporting centers of excellence, which is very exciting.
Yeah, amazing experience. Yeah, I think so. Yeah. So have we time for an extra questions, or we are on delay?
We are on delay, I think.
Okay. I'm tired.
It was great to have you both. And I thank Roger Hartl for his great efforts to provide a center of excellence in Tanzania. I will make one comment. Actually, even during the lifetime duration of one surgeon, we are skipping from making surgeries, open surgery, then microscopic surgery, then endoscope, then exoscope, recently augmented reality robotics. So then we are trying to adapt ourselves as surgeons to new technology, and probably we are missing how to evaluate patients, how to select proper patient for surgery. Those ideas are not so discussed too much. So then probably we are having some mistakes by new technology or innovations. What do you think about that, Roger?
Yeah, Mehmet, that was exactly my point. And I've gone through that evolution. You know, you focus on technology and you get excited by new technology. Now I'm actually come back to the basics, which is the patient evaluation, and how do you do that? And that's why I think that you as a spine surgeon, you need to practice in a multidisciplinary settings where you work with colleagues who don't operate but who help you treat the 95% patients who don't need surgery, and that allows you to make better decisions and then be more successful with those surgeons that you operate on.
And it's more important in spine surgery than in craniocerebral surgery, probably.
Yes.
Thanks a lot. Great interview. I think we shall go to this next session. We can close our session here.
Thank you,
Thank you, everybody.
Thanks
Thank you, Roger.
Thank you.
Thank you.
Thank you once again to our kind speakers. Thank you, Dr. Mehmet. Thank you, Dr. Uli, for hosting the session for us. Now, moving on, I would like